So, welcome friends. Today we are going to discuss some surgery questions, which are expected questions of FMGE exam, upcoming exam. So, I will be seeing for your answers in the chat box. First question: a 32-year-old trauma patient after RTA has a BP of 80 systolic and pulse rate of 110. You need to infuse quickly in this patient. Which IV line will you prefer for maximum IV fluid? So, which IV line? So, there are various color of vent flanks. You would have seen this question already. So, the color of vent flanks are gray, orange, green. So, these three vent flanks are used in road traffic accident. Please remember, we use only three vent flanks in road traffic accident. So, that is 18 gauge is green, 16 gauge is gray, and orange is 14 gauge. So, don't get confused in this. So, orange is 14 gauge. So, this is the biggest diameter. So, maximum fluid can be given with orange. In fact, 270 ml can be infused per minute in this orange color vent flank. Whereas gray color is second, it is 180 ml per minute. Green is 90 ml per minute. So, amount of fluid that can be infused is orange is 270 ml, gray is 180 ml, green is 90 ml per minute. So, the color of the vent flanks are 14, 16, 18, orange, gray, green. So, in trauma, we can only use these three colors. We cannot use smaller colors in trauma. So, in trauma, what is the color of vent flank used is only this three color. In this choice, you can see gray is the best one for maximum fluid infusion. The question is asking which can be maximum. So, here 180 ml is with gray compared with other smaller vent flanks. Gray is the best answer here for this choice. So, okay, please remember answer is gray. So, gray is 180 ml can be perfused. But if there is a choice of orange, I would have gone for orange, but orange is not there in the choice. So, I will go for gray. So, this is the first question. Let me give a fast review because I have made 50 questions for you. Just few hours from the exam. I don't want to waste most of your time. I'll finish off in 1 to 1.5 hours. Don't worry. Mr. Kumar, 50 years male, is planned for a thyroid surgery or head and neck surgery. So, when you're planning for a surgery in the head and neck or thyroid, you should put the patient in head up like this, head up like this, so that the vascularity in the head will be less, so that I can operate a thyroid or any parotid surgery. Anything I do in the head and neck, I will put the patient in head up position. So, this is a position shown here. Can you tell me what is the name of this position? So, this position shown here is called as what? Reverse Trendelenburg position. Try to attempt the answers. You can post in the chat box. So, you can always post in the chat box. Very good. I'm seeing you the chat. So, most of you are correct. It is reverse Trendelenburg position. So, reverse Trendelenburg position is used is nothing but head up position. If I am putting the patient in put up position like this, it is called as Trendelenburg. Trendelenburg position is used for varicose vein surgery. Okay, varicose vein surgery. Don't forget this. For varicose vein surgery, we put the patient in foot up position, foot up position. So, this is a very important question. So, there may be a question from the positions of the patient. I will not waste time on all the question discussion, all the choice discussion. I will discuss only the questions and the important points with the answer. If you have any doubts, you can post me so that I will clarify that. So, answer B is Trendelenburg position is for varicose veins. Reverse Trendelenburg head up is for this position shown here is the choice written here is wrong. So, don't worry. So, this is C. Answer what you have written is C is correct. So, answer is C. It is a reverse Trendelenburg position. Trendelenburg is for varicose vein. So, don't forget head up is for reducing the vascularity in the head. So, the answer will be C for this question. What is the ability of the suture material to retain its shape after removal from the suture packet? You want to explain other options? I will explain. But since you have short time, I don't know whether you will be able to wait for 2 hours. Okay, I will discuss other options also. So, please remember, if I take a suture material, so this is a suture material and this is a thread, needle with a thread. If it is in a packet, once I take it out of the packet, from the packet, usually all suture materials will fall like this. But one suture material will go for recoiling like this. So, it is a property called as, yes, memory. Very good. So, best answer here is memory. So, answer C can also be taken, but the best answer for this is Memory as well as elasticity both are correct, but the direct line from the book is memory. So memory is a property of proline. Don't forget, memory is a good property or bad property? Is a property of proline suture material. It is a bad property, okay, bad property. Because when you make a knot, the knot gets loosened. Therefore, it is a bad property of proline. So proline has this memory property. It is a bad property. It will go for recoiling. Therefore, the suture when I put will go for loosened. Therefore, I should make 6 to 7 knots when I use proline. I should use 6 to 7 knots when I use proline. Okay, this is a bad property. At what angle should the needle be inserted while suturing with the interrupted sutures? So this is a skin. Okay, this is a skin suture. I will take suture from here to here like this, and I will make a tie like this. This is a simple suture. So what I have drawn here is a simple suture. So the question is asking, when I'm entering, at what angle I will enter the needle and at what angle I will exit the needle. It is at, very good, most of you are very well prepared for the exam. So it is at 90 degrees. That is absolutely correct. So that is at 90 degrees we enter and 90 degrees we exit. So that is 90 degree. And what is X 2X rule in a skin suture? When I'm putting a skin suture, X 2X is, if X is the depth of the wound, okay, please remember, if X is the depth of the wound, I should take sutures at X distance from the incision. X distance from the incision, and next suture should be done at 2X distance. At this distance should be 2X. This is one rule from Weylian law, X 2X rule. So X is the distance between the two knots and 2X is the distance between the alternate sutures. So this is X distance, and if the depth is X, that suture taken at X distance from either side of the wound, this is a wound, okay, this is a wound, on either side I should take at X and I should approximate. This is X 2X rule. So what you are telling 3:1 is not for this. Jenkins rule, there is one more rule known as Jenkins rule. What is Jenkins rule? In a laparotomy, in an abdominal wound, if I'm doing an incision in the abdomen like this, if this is the incision, if it is 10 centimeter incision in the abdomen, how many sutures, how long centimeter the suture I should take? The length of suture should be how many centimeters? That is known as Jenkins rule. So the length of the wound is 10 means, so length of the wound into 4 is the length of suture material it is used. When I use a suture material, it should be length into 4. So it is Jenkins rule. So when the length of the wound is 10 centimeter, use suture of 40 centimeter. Use a suture length of 40 centimeter. The into 4. This is called as Jenkins rule for wound closure of laparotomy. Okay, abdominal wound closure. Okay, abdominal laparotomy wound closure. So you are seeing here a skin suture, very interesting type of skin suture, which is not seen outside. From very closely, if you observe, the skin suture is running underneath. It is running underneath the skin. It is not seen outside at all. So this suture is called as subcuticular suture. Now the question is, which is the best suture material for this subcuticular suture? Very good, Harsha, that is correct, 40 centimeter. Which among this is the best suture material for subcuticular suture? In this, polyglycaprone, also called as monocryl, please don't forget, also called as monocryl, is the best suture material for subcuticular. So here I will tell you some places what suture material used. Bile duct anastomosis, bowel anastomosis. What is the suture material used? Yes, it is polylactic acid, also called as 𝗲𝗿. We call it as 𝗲𝗿. Okay, company name is 𝗲𝗿. So bowel polylactic acid, that is called as 𝗲𝗿. So 𝗲𝗿 is a company name. Actually, we should not use that term. We should only use the term polylactic acid. But please remember, polylactic acid is a multi-filament material. Multi-filament material for bowel and bile duct. For bowel and bile duct, we use multi-filament material, polylactic acid. For blood vessel suture, blood vessel, vascular suture, what is used? Blood vessel, tendon suture, laparotomy wound closure. In all these places, we use polypropylene. Polypropylene is a proline. It is monofilament material. It is monofilament material. Yes, it is monofilament material called as polypropylene. That is used for blood vessel, tendon, laparotomy, hernia surgery and all. We use proline. For hernia surgery and all, we use proline as a material. So don't forget, here I have told you monocryl. Monocryl is for subcuticular suture. Subcuticular skin. It is a skin suture. We use monocryl. Actually, the name of monocryl is a company name. Original name is polyglycaprone. Glycaprone is the original name. That is a question asking. So we use a cutting needle. So we can use a cutting needle. Don't use round body needle in the skin. So round body needle and cutting needle. Cutting needle is used for skin sutures. Round body is used for bowel sutures. Needle should be round body in bowel. Cutting should be used in skin. Okay, please remember, suture material related a question can come for your exam definitely. Which of the following is not true regarding parenteral lines for nutrition? So I'm going to put a central venous line now. Question is on central venous line. So can you see the choice and tell me the answer? Central venous line is put in IJV, subclavian vein or femoral vein. 3 places you can put central vein. Either in the internal jugular vein or in the subclavian vein or in the femoral vein. So TPN is best delivered through a central vein is true. Subclavian vein has a higher rate of pneumothorax, yes, because it is gone below the mid-clavicular place, so you can injure the pleura very commonly, so high rates of pneumothorax. Subclavian central veins are easy to insert. No, subclavian central veins are difficult to insert and I need a ultrasound guidance is needed for subclavian vein. Femoral veins have highest infection rate described. So very good. All of you are correct. Answer is C. So don't forget subclavian vein, IJV. So this is a neck of the patient. From the picture itself, you can say which vein you have inserted. So this is the vein. If the vein cannula is seen in this place, it is IJV. If the cannula is seen below the clavicle like this, it is subclavian vein. So IJV is very easy to insert. Between the 2 heads of sternocleidomastoid, we can insert. Whereas subclavian vein, we have to insert it under ultrasound guidance. That is why it is more difficult. But advantage is it is comfort for the patient. Comfort after putting the subclavian vein, you can put a shirt and go anywhere. So comfortable for the patient. But complications are pneumothorax is more common. So now there is a very common question in this. In a trauma patient, I am going to put a central vein. Which vein will I use? In a trauma case, which vein I will use? If I want to give nutrition for a patient, total parenteral nutrition for a patient, which vein will I use? Yes, this is the classical NEET PG question. For a trauma patient, I will use IJV. For a nutrition, I will use subclavian vein. So femoral vein, we usually don't use. Only for blood sample taking and all, we use femoral vein. Otherwise, femoral vein has high chances of infection. So we don't use them commonly. Okay. So trauma patients, internal jugular vein is used. For long-term nutrition, I will use subclavian vein. But subclavian vein, please don't forget, pneumothorax chances are very common. Which dietary component is lacking in patients started in patients on TPN? So this is a question on patients who are on total parenteral nutrition. What are the components present? So I hope you remember the total parenteral nutrition bag made up of 3 components like carbohydrate, proteins and lipids. Carbohydrate is 60%, protein is 20%, lipid is 20%. So this is a classical question. It is not containing fiber. Okay, this is classical MCQ. So don't forget 60, 20, 20 is a normal TPN. So there is another TPN called as fat-free TPN. Fat-free TPN is made up of only 2 components, that is carbohydrate and protein. This is 75% and protein is only 25%. This question has come in NEET PG exam. Carbohydrate and protein are present in 3:1 ratio in a fat-free TPN. Fat-free TPN is used for patients who are having jaundice and fatty liver. Okay, don't forget fat-free TPN. So TPN is a favorite question for your exams. Just have an idea about TPN. So when you are going to give TPN for a long period of time, patient may develop refeeding syndrome. Refeeding syndrome is a complication of TPN in which there is PCM decreased. Remember this mnemonic. PCM decreased. Potassium plus phosphate decreases. Calcium decreases. Magnesium decreases. This question is a favorite question of National Board examiners. On a TPN, patient on TPN can develop a refeeding syndrome. There is a big mechanism. No time for explaining all those things. Just now remember there is a decrease of potassium, calcium, magnesium. So this is very important. And these patients can die. Very good, Varsha. That is correct. Patients can die of hypokalemia-induced arrhythmia and congestive cardiac failure. Patient can even die of this problem. So please don't forget this question. 70 kg male presents to emergency following a stab injury to the abdomen. His pulse rate is 130 per minute. See, pulse rate increased. BP is 90/60. So BP is decreased. So what is this grade of hemorrhagic shock? Yes, the answer here is, see, let me discuss classes of hemorrhagic shock. So please don't forget this question is a last minute important question. Class 1, class 2, class 3. There are 4 classes of hemorrhagic shock. In class 1, the amount of blood loss is 15% or 750 ml. 15 to 30% or 750 to 1500 ml. Class 3 is 1500 to 2000 ml or 30 to 40%. Class 4 is more than 40% or more than 2000 ml. This is the blood loss percentage. In class 1, there is no change in anything. Everything is normal. BP normal, pulse rate normal, everything is normal. Whereas in a class 2, the first sign is pulse rate increases, respiratory rate increases. So this is a finding in class 2 shock. In class 3 shock, systolic BP decreases from class 3 shock. Class 4 shock, patient goes for anuria. Urine is not functioning, coming out. Urine output decreases from class 3 shock, but class 4, patient goes for anuria. So this is a last minute important point you should not forget. Pulse rate and respiratory rate increase from class 2. In class 3, systolic BP decreases. That is what mentioned. BP is 90/60. So it is class 3. Okay, class 3 shock. Don't forget class 3 shock. So in otherwise, this is also mentioned as class 2, class 3, class 4. Other names are asked in your exam. Class 2 is mild shock. Class 3 is moderate shock. Class 4 is severe shock. Class 2 is mild shock, also called as compensated shock. Means what? BP is normal. BP is compensated. So that is called as compensated shock. Class 3 and 4 are called as decompensated shock. This question came last year in your exam. So in which shock there is fallen systolic BP? The answer is moderate shock. Mild, moderate, severe. Moderate shock, there is a fall in systolic BP. Otherwise, class 3 shock is the answer, also called as decompensated shock. So please remember this slide for last minute of your exam. And always there will be a question on Glasgow coma scale. All of you know that scale very well. So a 32-year-old male is brought to emergency with an RTA. He is opening his eyes to painful stimulus. Now tell me, so eye opening points. Spontaneously, if he is opening, that is 4 points. When you open his eyes on commands, it is 3 points. Opens to pain is 2 points. Not opens is 1 point. So it is, the answer from this is E2, E2. And verbal is words. Verbal response, I used to always tell a mnemonic. One confused word sounds nowhere. That's a mnemonic. One confused word sounds nowhere is the answer for that. Please don't forget, 1 stands for patient oriented, 5 points. Confused, 4 points. Inappropriate word, 3 points. Bad sounds, 2 points. No sounds, 1 point. So the question is telling about inappropriate words. So we will go for 3 points. Verbal, 3. So E2, V3. So what is motor? On painful stimulus, is localizing pain on the left side, but right hand goes to abnormal flexion. So 2 different values are there. Let us see now what is motor response. So motor response, obey, mnemonic for this, obey localites with flexion extension. Yes, this is a 1000 times asked question. You should definitely read this and never make a mistake in this question. There will be no excuse if you make mistakes in these type of questions. Obeys command, that is 6 points. Localizes pain, 5 points. When you touch him, he is withdrawing, 4 points. Flexion deformity, 3 points. Extension deformity, 2 points. No response, 1 point. So in this picture, there is a 2 values. Left limb localizes pain, right limb flexion. So right limb flexion, left limb localizes. So which one will you take now the score? Which score is taken for the motor? See, which one will you take means the best one is taken. So the motor score is M5. So take the best. If there are 2 different values, take the best value is the answer for this question. Please don't forget this question on Glasgow coma scale. Again, another 100 times asked question. What is mean by triage? Triage is to classify the patient according to the priority of treatment. Okay. So yes, it's always the best one is taken. So priority of treatment is triage. So triage, I have 50 questions, not 30 questions. So triage is, don't forget the mnemonic RYGB. So red should be treated within 30 minutes. Yellow should be treated within 2 hours. Green, they are walking wounded. They can go to their native place for management. Walking wounded patient. Black is a dead and moribund who is about to die. You cannot save him. Moribund patient. So in a red comes tension pneumothorax. Tension pneumothorax, pericardial tamponade. Pericardial tamponade and all will come under red badge. Okay. So green is an ambulatory or walking wounded. No need to admit them. Let them go to their native place. Yellow includes femur fracture, fracture of bigger bones, where there is huge amount of blood is lost. So black includes crush injury of skull. A skull is crushed with the brain exposed, a run over of the lorry tire on a chest, all those things who cannot save them. That is known as crush injury. Yes, many of the injuries which can be managed like flail chest, rib fractures, all those will come under yellow. Okay, so no need to worry about yellow. Also is nothing to worry, but most important is red. Red is which should be treated within 30 minutes. So don't forget triage colors. That is priority of treatment based on the type of injury. Based on type of injury. Okay, that is known as triage. 20-year-old boy presented to emergency after road traffic accident. Patient has a GCS of 6. Glasgow coma scale 6. Pulse rate 100, BP, whatever it is. What is the first step? Can you tell me the answer? This question is a repeat question. Which is the first one? Management. So this is based on the mnemonic ABCDE. So this is a trauma patient coming to you. We should always treat according to the mnemonic. A for airway, first airway. B for breathing. C for circulation. D for disability. Finally, E for exposure. So in this patient, airway, please remember, when will you intubate? When the GCS is less than or equal to 8, we should intubate the airway. Therefore, the GCS here is 6. Therefore, I have intubated the patient. First step is less than 8. We should intubate the patient first. So after intubating, we will connect him to a ventilator second. Then I will start the IV fluids and start the fluid flow. So CT scan is not a part of primary survey. It comes under secondary survey. So all these come under primary survey. Okay, CT scan is a secondary survey. Don't forget that. So what will come under secondary survey means CT scan is a secondary survey. An adult patient presents after blunt trauma in the abdomen. Patient is complaining of left upper quadrant pain. Vitals are unstable. What will you do for the next step? Yes, what is the next step in a blunt trauma protocol? Yes, blunt trauma protocol, you all know very well. It is immediately fast. Blunt abdominal injury. First point, blunt abdominal injury. Whatever the patients, you should do A, B, C, D, E. Any trauma patient, A, B, C, D, E. After doing A, B, C, D, E, you should do E fast. E fast focuses on 6 regions. Don't forget it. Focuses on 6 regions. We have to do ultrasound done in 6 regions. One is right side hypochondrium for liver, left side for spleen, epigastric region for heart, and pelvis for any collection. So 4 regions plus right and left chest. So 6 regions are ultrasound. But 𝗲𝗏ast can detect more than 100 ml of blood only. 𝗲𝗏ast cannot detect bowel perforation. Cannot detect bowel perforation. Don't forget, these are all basic points. Should not forget. After doing 𝗲𝗏ast, if patient is stable, I should also do a CT abdomen. If patient is unstable, I should take him for a surgery. That's all. So blunt abdomen, 𝗲𝗏ast is a main deciding factor. If patient is stable in a 𝗲𝗏ast, I will take him for a CT abdomen. If patient is unstable, I will take him for a surgery. So the patients are unstable. So I will do fast, then only I will go for laparotomy. Don't forget this. They're asking, what is the next step? Next step is first, you should do fast, followed by laparotomy. So the answer is B for this question. 20-year-old boy is presented to the emergency following road traffic accident with respiratory distress and hypotension. He has subcutaneous emphysema, no air entry to the right side of the chest. What is the next step? So classical question of pneumothorax. So don't forget the classical step of pneumothorax. What should I do? Yes, very good. Immediately put a needle. So protocol in tension pneumothorax. This is a lungs which is compressed. This is full of air. So there is air in this chest. So what happens? Because of pneumothorax, there are 3 points happening. One is absent breath sounds on the right side of the chest. Number 2, trachea or mediastinal shifted to opposite side. Number 3, raised JVP. Number 4, low BP. So these are the 4 features of pneumothorax. Absent breath sounds, trachea shifted to opposite side, raised JVP, low BP. Immediately, it's a red emergency in the triage. Put a needle in. If the needle in adult is 5th intercostal space, mid-axillary line. If it is a child, it is 2nd intercostal space, mid-clavicular line. But this is only a first aid. You should always plan for a ICD tube at 5th intercostal space, mid-axillary line is a treatment of choice. Next done treatment is needle, but treatment of choice is intercostal drainage tube in the 5th intercostal space. Don't forget, don't make mistake in pneumothorax. There is no excuse if you make mistake in pneumothorax type of questions. So coming to thyroid. After thyroid surgery, a patient is unable to shout. What is a nerve injured? So the patient had a thyroid surgery. After surgery, when you are asking him to shout, he is unable to shout. His voice becomes huskiness or loss of pitch. What is the diagnosis? Yes, excellent. All of you answered it very correctly. It is external laryngeal nerve. So please don't forget, there are 3 nerves which can be injured. External laryngeal nerve, internal laryngeal nerve, recurrent laryngeal nerve. 3 nerves can be injured in a thyroid surgery. These 2, external as well as internal, both are branches of superior laryngeal nerve. So external laryngeal nerve is a pure motor nerve which supplies cricothyroid muscle. So as I injure the external laryngeal nerve, because that is the most commonly injured nerve, is external laryngeal nerve. So if I injure this nerve, patients will have loss of pitch. He cannot shout. If I injure internal laryngeal nerve, it is sensory nerve above vocal cords. Sensory above vocal cords. So this patients will have cough, paroxysmal cough. That means nocturnal. In the night time when they lie down, they have cough. Recurrent laryngeal nerve injury is very dangerous. It is both motor as well as sensory. So when I injure unilateral nerve injury will usually cause hoarseness. Okay, hoarseness alone. Whereas bilateral nerve injury is the most dangerous, which will cause stridor. So don't forget the nerve injuries from thyroid surgery. Definitely there will be questions from thyroid injury. So recurrent laryngeal nerve injury, unilateral hoarseness, bilateral stridor. So when the patient goes for bilateral recurrent laryngeal nerve, it is very dangerous. Okay, it will go for very dangerous injury, stridor. So don't forget this. Among these nerves, least commonly injured is 𝗪𝗪 cervicalis. Most commonly injured is external laryngeal nerve. Okay, least commonly injured is 𝗪𝗪 cervicalis. If I diagnose recurrent laryngeal nerve injury, RLN injury diagnosed during surgery, on table if I diagnose it, I should repair it using which nerve? Repair with 𝗪𝗂 cervicalis nerve. Okay, that is a on-table graft can be taken from 𝗪𝗂 cervicalis for repair of RLN injury if it happened on the table. Okay. Which one of the following is not true regarding cardiac tamponade? I just now told you a pneumothorax. Cardiac tamponade is characterized by Beck's triad. Beck's triad is raised JVP, low BP, and muffled S1, S2. Muffled S1, S2 is cardiac tamponade. It is a clinical diagnosis which can be supported by 𝗕FAST, correct? Needle pericardiocentesis should be done under ECG control as arrhythmias are common. X-ray shows ice bag appearance. Yes, correct. Now the latest answer from new edition is needle pericardiocentesis is no more advised. No more advised. That is a new answer now. So please don't forget needle pericardiocentesis. You should understand what is cardiac tamponade. This is a heart. Around the heart, we have a thick pericardium. If there is a penetrating injury of the heart, the blood will start leaking into this area. So slowly, it will compress the heart and the patients will develop the typical Beck's triad. Now the question is, because of the Beck's triad, patient is having low BP, raised JVP. Old editions will usually say, I will put a needle at this place and tap the blood. We'll put a needle at this place and tap the blood using needle pericardiocentesis. That is no more advice. Latest treatment is we should take them for thoracotomy and repair. Needle pericardiocentesis is no more done. Please don't forget, needle pericardiocentesis is no more done. That is the latest answer from New Bailey. So not done now for cardiac tamponade. Please remember this. So 60 kg man suffers 30% second degree burns at 6 p.m. What is the amount of fluid required till midnight to the new ATLS formula? So let us come to the new ATLS formula. So this question, so what is the amount of fluid should be given till 12 p.m. 12 midnight. So from 6 p.m. till 12 midnight, what is the amount of fluid to be given? We are going to calculate. Little catchy question. First of all, let us calculate according to ATLS formula. So according to ATLS formula, amount of fluid should be given as 2 into weight in kilogram into total body surface area. That is a new ATLS formula. Please don't forget, that is a new ATLS formula. 2 into weight in kilogram into total body surface area. 2 into what is a weight in kilogram? It is 60. Into total body surface area, 30%. So luckily, they are not asking you to calculate. So the answer is among these three, either 2, some of this is correct. 4 is for old Parkland formula. So leave with that formula. So now, what will I do for the first 8 hours? So 6 p.m. to 12 midnight. So it should be around 6 p.m. is the degree of burns at 6 p.m. 6 p.m. to 12 midnight. It is 6 plus at least up to 12 midnight means it should be up to first 12 hours. You should give half the volume. So within the first 12 hours, I should give half the volume. It should be given in the first 12 hours. That will be the better answer. So don't get confused in this. This question is a hypothetical question. Among the fluid calculated, half should be given in the first 8 hours. Remaining half is given in the second 16 hours. The question I want you to remember here is, this first 8 hours is from the time of burns, okay? From time of burns, not from time of admission. It is not from time of admission. Whenever the patient, for example, instead of 6 p.m., if the patient got admitted at 10 p.m., I should give within next 2 hours, I should give half the fluid. That is the question. So whatever the time of burns, I should calculate from the time of burns, not from the time of admission. So remember that. So half of the fluid should be given in first 8 hours. Remember this question. Which among the following statement is not true regarding thyroglossal cyst? It's a favorite national board question. What is thyroglossal cyst? Which is not true. Can you tell me the answer in this? Moves with the deglutition and protrusion of tongue. Moves with the protrusion of tongue. Yes. Cyst trunk operation is the procedure of choice. Yes. Follicular cancer is the commonest cancer. Most common is 𝗶𝗲𝗃𝗏. Yeah, answer is not follicular cancer. It is papillary cancer. Okay. So please understand thyroglossal cyst. So this is foramen cecum of tongue. From here, the tract descends down is called as thyroglossal tract, which gives thyroid gland. So residual cyst in this tract, some residual cyst in this tract is called as thyroglossal cyst. Since it is attached to the tongue, it moves with the deglutition. This is the hyoid bone. It is usually seen below the hyoid bone in the midline. It is common in the age group of 5 to 15 years girls. Most common in 5 to 15 years girls. This can go for many complications. Most common complication is infection. Most common complication is infection forming thyroglossal fistula. Another complication is papillary cancer. So the point we should do here is I have to resect this cyst along with the central hyoid bone. I should remove the cyst along with the entire tract, along with the central part of hyoid bone, not full hyoid bone. Central part of hyoid bone is removed. That is called as cyst trunk operation. Okay, cyst trunk operation is the surgery done for these cases. Very good. So a patient who received radiation to the neck, 18 years of age, now notice the midline swelling in their neck. See, for your exam, don't get scared with such type of bigger questions. So always these type of big questions will have a simpler clue to come to a diagnosis. So let us see what is the simple clue in this question. So 18 years age, notice the radiation was given before. Now she is coming to you with the midline swelling. A small lesion is noted in the right lobe of thyroid gland without any lymph node. Ultrasound reveals it to be a papillary. So the point is over. This is the case of papillary cancer. For a papillary cancer, what is the treatment done? So the answer is very clear. It is papillary cancer. You can go for HEMI or total thyroidectomy. So you can go for HEMI or total thyroidectomy. But the point here, I have gone for a total thyroidectomy. Let me tell you the reason. So for a papillary cancer, if it is in one lobe, when all can I do hemithyroidectomy? So usually we do total thyroidectomy only. Don't forget that. Since it is a cancer, we always do total thyroidectomy only. No doubt in that. So answer is total thyroidectomy in this question. But some cases I will do hemithyroidectomy. That is based on many grading system like AGAS grading, AMES grading, MASIS grading. Many grading are available. According to these grading, just remember, if the size of the lesion is less than 4 centimeter, okay, size of the lesion is less than 4 centimeter, no extrathyroidal extension. So nowadays, for smaller lesions and no extrathyroidal, no multifocal lesions, they are doing hemithyroidectomy also in such cases. But in this patient, you can see why I am not doing hemithyroidectomy, but I want you to do total thyroidectomy because the following are contraindications like radiotherapy, radiation-induced papillary cancer. This is a case of radiation-induced papillary cancer before. See the question, who received radiation in the neck, therefore that is a clue. Since patient had radiation in the neck, so she can develop cancer in future in this remaining gland also. Since it is radiation-induced, though the size of lesion is only 2 centimeter, I am going for a total thyroidectomy. Otherwise, please remember, always we should do total thyroidectomy only. New concept from 28th edition Bailey. Some cases we can also do hemithyroidectomy if the lesion is very smaller. According to new grading systems, if it is less than 4 centimeter, we can do hemithyroidectomy can also be done. In this case, I'm not doing because this is radiation induced. So radiation can cause cancer in the remaining gland. Better to go for removal. Okay, that is a point. You should not forget. New update from Bailey 28th edition. 25 years old female presented with a diffuse thyroid swelling. Biopsy shows Hürthle cell. So what is the diagnosis? Simple, straightforward question. Repeated MCQ for your exams. Hürthle cell positive is nothing but Hashimoto's. Okay, Hashimoto's is the most common cause of Worldwide hypothyroidism. Worldwide hypo is because of Hashimoto. So all of you know very well about Hashimoto's. Please don't forget FNAC shows Hürthle cells. And most important test you should do in Hashimoto's is autoantibodies. There will be autoantibodies. What antibody is most commonly elevated? Can you tell me what antibody is most commonly elevated in thyroid peroxidase? Okay, thyroid peroxidase antibody. Very good, Puneet. That is correct. TPO. TPO is the most commonly elevated autoantibody. Don't forget this for your exam. For Hashimoto's, thyroid peroxidase is the most important antibody. Nipple discharge related question. Breast cancer is the most common cause of bloody nipple in old age. Most common cause of bloody nipple discharge in old age is breast cancer. True. Duct ectasia is a common cause of greenish discharge. Paget's disease is erosion of nipple with discharge. Duct papilloma is associated with greenish yellow discharge, which is wrong. Duct papilloma is associated with bloody nipple discharge. So most common cause of bloody nipple discharge in young age is what? It is duct papilloma. So please don't forget what are these. See, in a breast, this is nipple. These are the ducts. All the ducts will converge towards the nipple. So totally there are 15 to 20 ducts. If the ducts becomes abnormally dilated like this, it is duct ectasia. If the duct contains a polyp like this or a papilloma like this, it is duct papilloma. So duct papilloma presents with bleeding, bloody nipple discharge. Duct ectasia presents with yellow-green discharge. Okay. Abnormally dilated duct will present to you with the yellow-green discharge. Duct papilloma will present to you with the bloody nipple discharge. Don't forget this. 36 years old patient. I'm covering the entire surgery in this 50 questions, right? From general surgery to specialty, all the topics I am just touching. So that will be a fast revision for you. 36-year-old patient is diagnosed with a locally advanced left breast cancer. IHC markers are ordered. Tumor is positive for ER, PR, and HER2 negative. So this is a case of ER positive, progesterone receptor positive, HER2 negative. So this is a case of ER, PR positive, HER2 negative. Which one of the following statement regarding this patient management is not true? So when ER, PR positive, I can give hormone therapy. Okay. Locally advanced breast cancer is stage 3. Stage 3 breast cancers will benefit from neoadjuvant chemotherapy. HER2 negative. So what is no use? Which is not true. HER2 negative means this is not used. How can I give Herceptin? No use. No, there is no use. Radiotherapy will be required. Yes. See, please understand, this is a case of locally advanced breast cancer. All locally advanced breast cancers are nothing but stage 3A, B, C patients. All these patients will be treated first with neoadjuvant chemo-RT. So neoadjuvant chemotherapy. So what is done? Neoadjuvant chemotherapy is done. Then we will do modified radical mastectomy, in which minimum how many nodes should I remove? Minimum 10 nodes removed. After doing the surgery, I should give adjuvant chemotherapy, hormone therapy, radiotherapy in these patients. So hormone therapy is given if estrogen receptor positive and progesterone receptor positive. If it is negative, no use. Chemotherapy is continued same, and if the patient is HER2 positive, I should also give anti-HER2 antibodies, trastuzumab. If it is negative, no use. There is no use of giving the antibodies. Yes, very good, Chepuri. That is 10 number of nodes are removed in cancer breast. Minimum number of nodes removed is 10 nodes in a cancer breast operation. A patient accidentally after MRM pulls out her drain after mastectomy. Fullness develops in the region after surgery because the most common complication after mastectomy is what? Most common complication after mastectomy is seroma collection. So to remove the seroma, we usually keep a suction drain. So when will you remove the suction drain? Suction drain is kept usually will be removed after 5 days only. But if seroma is an uncommon, which of the following statement is correct? They're asking. Is an uncommon is wrong. It is a common complication. Seroma should be aspirated under aseptic condition. So after removing this, there is a collection aspirated. So that should be aspirated. That is true. Increased incidence of seroma is associated with increased incidence of lymphedema. No, that is not correct. So nothing to worry, it can be left as such is also wrong. So we have to aspirate the seroma and make a tight dressing. So increased incidence of seroma does not mean it will cause increased risk of lymphedema. That is not the meaning. So it is probably the seroma gets collected, we have to aspirate, or we should keep a suction, Romovac suction drain for 5 days. The answer is B. So this question is again a favorite question of National Board examiners on molecular classification. Luminal A type, luminal B type. There are many types: luminal A type, luminal B type, basal type, HER2 type. So now from the question, ER-PR positive, HER2 negative, KRAS is low. What is this? So please remember, ER-PR, HER2, KRAS. So ER-PR positive, HER2 negative, KRAS is decreased is luminal A type. ER-PR positive, HER2 can be negative or positive. It can be either negative or positive, but KRAS is high, that is luminal B type. So new update from Bailey, it can be either negative or positive, but in case of luminal B type, KRAS is increased. So basal, very interesting and easy question. If you are all negative, you go to the base. Remember like that. If you are all negative, you will go to the base. Therefore, this is the worst prognosis. So HER2, only HER2 positive, other guys are negative. Therefore, they also have a bad prognosis. So best prognosis is luminal A type. So please go through this luminal A type and B type alone thoroughly. Okay. How to differentiate luminal A and luminal B is by doing a KRAS. KRAS is low in A type and B is having high KRAS. So new Bailey has updated. B type is luminal A positive, B positive. HER2 can be negative or positive. But Bailey shows only minus type in B. But actually it can be either negative or positive. Two types are there in luminal B. So this is a question on A. Usually they will ask for FMGE exam only luminal A. So be thorough with the luminal A. A patient presents with a hernia. This is a direct question for your exam. Hernia medial to the inferior epigastric artery. So what is the diagnosis and what is the treatment for this case? So when a hernia is medial, it is what hernia? Anterior superior iliac spine, pubic tubercle. This is anterior superior iliac spine, pubic tubercle. This is inguinal ligament. And this is external iliac artery. This is inferior epigastric artery. This is rectus abdominis muscle. Okay, this is rectus abdominis muscle. If a hernia happens through this triangle, it is known as direct triangle. Direct hernia. So that is known as Hesselbach triangle between rectus abdominis, inferior epigastric artery, inguinal ligament is called as direct hernia. So direct hernia happens through here. Indirect hernia happens from deep ring like this. So indirect hernia appears lateral to the inferior epigastric artery. Direct hernia appears medial to the inferior epigastric artery. Treatment is Lichtenstein mesh repair. So we cannot do herniorrhaphy for direct hernias. So we have to do direct hernias will be treated by Lichtenstein mesh repair. So there is always a new update related to laparoscopic anatomy. Triangle of doom and triangle of pain are important landmarks during laparoscopic hernia repair. Which of the following do not form boundary of any of these triangles? Any of these triangles which is not a boundary. Very simple, straightforward question. Okay, the answer is Cooper's ligament. Those who have not read this concept, I'll make it so simple. I'm drawing the same inguinal hernia anatomy. This is from above. This is testis and this is peritoneum. Okay, this is a peritoneum. So now you can see this deep ring is a opening which can be seen in laparoscopy from inside. Into this, you can see the following structures enter. This is vas deferens which is entering the deep ring. This is gonadal artery and gonadal vein entering here. Testicular artery and testicular vein entering here. This area is inguinal ligament anteriorly. Posteriorly, we call it as iliopubic tract. This is iliopubic tract. Now you can see two triangles. This is yellow color is one triangle, and what I'm now drawing in blue color is another triangle. So triangle of doom bounded by vas, gonadal vessels, peritoneum. Triangle of pain bounded by gonadal vessels, iliopubic tract, peritoneum. So don't forget these two triangles, because when I'm doing laparoscopic surgery, I will define these two triangles and I keep a mesh. So triangle of doom and triangle of pain are favorite national board questions. Don't forget this. Triangle of doom contains what contents? External iliac artery, external iliac vein. Triangle of pain contains lateral cutaneous nerve, anterior cutaneous nerve, femoral nerve, genitofemoral nerve. So these are the nerves present in this triangle of pain. That is why if you do anything in this triangle of pain, the patient will have persistent pain. That is why we call it as lateral cutaneous, anterior cutaneous, femoral and genitofemoral nerve. So don't forget these two triangles for your exam. So now a question on parathyroid hormone related to 𝗵𝗵 criteria. 𝗵𝗵 criteria. This question is a simple, straightforward question asking about 𝗵𝗵 criteria. That's all. So a patient comes to you with a parathyroid adenoma. Parathyroid adenoma. So what it will do? It will secrete excessive parathyroid hormone. Patients will develop many complications like kidney stones, pancreatic stones, pancreatitis. Many problems will happen. I'm not going into that. When I'm doing surgery, I have to remove this adenoma completely. I have to remove the adenoma completely. After removing the adenoma, I should check for pre-op parathyroid hormone level and removal. After removal, what is the level? This should be done. This is called as 𝗵𝗵 criteria. So can you tell me the answer? Intraoperatively, parathyroid hormone assays provide guidance that all the hyperfunctioning glands has been removed during parathyroidectomy. What criteria is used to indicate satisfactory resolution of hyperparathyroidism? The answer is very clear. More than 50% fall in parathyroid hormone level. So for example, preoperatively it is 200. After surgery, it should be less than 100. Fall in more than 50% within 15 minutes of removal of parathyroid hormone is the correct answer in this. This is called as 𝗵𝗵 criteria. So 𝗵𝗵 criteria, more than 50% fall in parathyroid hormone level in 10 to 15 minutes. That is the answer. Please don't forget this question. Straightforward FMGE question. 𝗵𝗵 criteria. So undescended testis. Which of the following is false statement? Yes. So these are all common topics. I have made question little tougher, but questions are very common questions. Undescended testis. Superficial inguinal pouch is the common site. Diagnostic laparoscopy is the investigation of choice in intra-abdominal testis. Absent testicular vessels on laparoscopy denotes an absence of testis itself. There is no testis itself. Undescended testis should be operated before 1 year. So which is wrong in this? Yes. Answer is superficial inguinal pouch is a common site is wrong. See, don't forget this is undescended testis concept. So testis is an organ from the lumbar region. From here it descends and comes here via deep ring, via superficial ring. By 9th month, it comes to the scrotum. It comes to the scrotum by 9th month. So as it is coming, the most common site of arrest is where? It is usually seen in the inguinal canal. Superficial inguinal pouch is here. It is not related to undescended testis. It is the most common site of ectopic testis. Ectopic testis most common site is superficial inguinal pouch. So don't get confused between undescended testis and ectopic testis. Ectopic testis is not in the normal route itself. It is a different route. It has gone to the superficial inguinal pouch. That is ectopic testis. Undescended testis is usually seen in this line. Usually found in the inguinal canal. If it is not in the inguinal canal, it can be in the intra-abdominal itself. In such cases, investigation of choice is diagnostic laparoscopy. In a diagnostic laparoscopy, if I am seeing the deep ring with no entry of artery, testicular artery and testicular vein, not at all entering inside, means there is no testis at all, absent testis. That fellow has lost his testis intrauterine. Now read the choices. Superficial inguinal pouch is a common site of ectopic testis, not undescended testis. So this is wrong. Diagnostic laparoscopy is the investigation of choice in intra-abdominal testis. True. Absent testicular vessels on laparoscopy denotes an intrauterine torsion or absent testis. That is true. Undescended testis operated by 1 year. By 1 year, it should be operated. Okay. That's a classical question on undescended testis. Please don't make mistake in that. So we are discussing some questions from urology. 23-year-old horse jockey sits the saddle hard after a jump and presents to the hospital with the complaints of inability to pass urine and blood at the tip of the meatus. The digital rectal examination is normal. What is the most likely injury? Yes, this is an urethral injury, no doubt. It's a urethral injury, presents with blood at urethral meatus. Blood at urethral meatus plus retained bladder. Retained full bladder. This is the presentation of urethral injury. So now the question is asking which urethra is injured. So the answer is B. It is the straddle injury. I hope you remember the class. I have told you a person walking into a manhole. The patient puts both foot into the manhole. The groin gets injured. No, that is a bulbar urethral injury. So this is bladder. This is prostate. This is prostatic urethra. This is membranous urethra. Okay, membranous urethra is usually injured in fracture pelvis. This is bulbar urethra. This bulbar urethra is usually injured in straddle injuries. Straddle injuries. Okay. So this is very important. So straddle injury is bulbar urethral injury. Membranous urethra is fracture pelvis. So this is penile urethra. So there are 4 parts of urethra. Okay. So when you see bulbar urethra is injured in straddle injuries, membranous urethra is injured in fracture pelvis. Whatever may be the injury, there is a disconnection, means they will have blood at the meatus and there will be full bladder. Okay, full bladder. This is very basic question. You should not forget. So this is nothing to mug up. You just remember, bulbar urethra is in the groin. Membranous urethra is higher up, very close to the prostate. So membranous urethra will rupture only in fracture pelvis. Bulbar urethra will rupture in straddle injury. In this question, you can see presents to sits the saddle hard after a jump in a hockey ride. So therefore, is bulbar urethra got injured. So the rupture of bulbar urethra is the answer for this question. A child brought to the clinic for evaluation of recurrent UTI, IVU is shown below. What is the most common, what is the diagnosis from the image? It's an IVP showing intravenous pyelogram, showing what sign is this? So you can see from this picture, it is a drooping lily sign. This is a renal calycis, which is pushed down and the kidney is like this, because something in this place is pushing. Something in this place is pushing. This is drooping lily, very good. So drooping lily sign is seen in 2 conditions. Number 1, ectopic ureter. Number 1, ectopic ureter. Number 2, another cause of this problem is neuroblastoma. So there are 2 places where you get drooping lily. So from this question, the answer is D. Duplication of renal pelvis, also called as, another name of this is ectopic ureter, ectopic pelvis. So because of the ectopic ureter, there is a pushed out kidney that looks like a drooping lily sign. So don't forget all the other image signs. Where will you get spider leg appearance in IVP? Spider leg appearance. Yes, answer the question. Spider leg, flower vase appearance, fish hook appearance, fish hook like this. Okay, where will you get cobra head appearance on IVP? Where will you get golf hole ureter on IVP? Very simple questions. Please don't forget spider leg and polycystic kidney disease, flower vase and horseshoe kidney, fish hook in retrocaval ureterocele will get cobra head for in the hospital for evaluation. On examination, the following crystals are seen. What is the name of this crystals? This is, I don't think there is no lag in me. I am also seeing the video. There is no lag. Please check your net. My net is fine. I'm also seeing here. This is multifaceted appearance in uric acid. Okay. So this is envelope shaped crystals. Where will you get? Envelope shape, also called as bipyramidal. Envelope shape or bipyramidal is calcium oxalate. Dumbbell shape is calcium oxalate monohydrate. Coffin lid, see the coffin lid, like a coffin cover, no? It is seen in triple phosphate, also called as 𝗬𝗏. Hexagonal crystals seen in cystine stones. Multifaceted stones like this. Multifaceted is uric acid. Uric acid is multifaceted. So don't forget the urinary crystal examination to diagnose the stones. So which of the following statement is false regarding the stones shown in the X-ray KUB? So you can see a classical picture of staghorn stones. These are staghorn stones. Staghorn stones also called as triple phosphate stones. They are found in alkaline urine. Okay, they are found in alkaline urine. So they are asking which is false in this. So they show coffin lid crystals. True. It is secondary to infection. Yes, it is caused by secondary to infection. Formed not in acidic urine. It is formed in alkaline urine. It is made up of calcium, magnesium, ammonium, triple phosphate stone. So the classical FMGE question, staghorn stones, don't forget. Okay. Which of the following substance is not used as an irrigant during monopolar for transurethral resection of prostate? So don't forget, when I'm doing a transurethral resection of prostate using a cystoscopy, this is a prostate, I'm going to cut and remove it. The distal limit of transection is going to be virumentanum. Virumentanum is the last point of transection. When I'm doing resection like this, ideal fluid I should use is isotonic glycine. But it is very costly. So in government hospitals, we use distilled water. Government hospitals, mostly we use distilled water, but we should not use normal saline. Because when I'm using normal saline for wash during cutting, so the diathermy, the current will pass out everywhere. So normal saline should not be used. So normal saline is contraindicated intraoperatively, but it is the fluid of choice for post-operative irrigation. Post-operative wash, we use this as a fluid of choice. So that is a classical FMGE question. A patient underwent TURP in the morning. Evening, you are going for a ward rounds. Patient is having disorientation. What is the cause? Disoriented after TURP in the evening. What is the reason for this? It is due to distilled water is used, no? So it caused water intoxication. It is because of water intoxication causing dilutional hyponatremia. Don't forget, this is a commonly asked FMGE question. So following a TURP, patients can go for water intoxication. As we are doing irrigation and wash, the water will enter the blood circulation and cause water intoxication, causing dilutional hyponatremia. So now there is a question on transplant related point. Using a porcine heart valve in human classifies as which transplant? So porcine heart valve. So using a pig or another animals is called as what? That is what they're asking. Xenograft is from another species. Allograft is from same species. Graft taken from same species. Isograft is identical twins from own body. If you take a graft, skin graft from your own body and put it somewhere, it is autograft. This is a microbiology cum surgery question. Don't make mistake in this. Identify the pressure source shown in the image. What is the grade of this pressure source? Grade 1 is erythema alone is seen. In a bed sore, if there is only erythema, It is grade 1. Partial thickness skin loss is grade 2. Grade 3 is full thickness of skin is lost. Grade 4 is bone exposed. So the answer is D. All these are repeat questions asked already in your exams. So grade 4 is bone is exposed. So the classical question on pressure sore, bed sore or pressure sore. Answer is bone exposed in this. So which of the following is not true regarding congenital diaphragmatic hernias? So let me draw the anatomy of congenital diaphragmatic hernia before going to the discussion. Please remember, this is diaphragm. In a newborn baby, this is one defect which is normally seen, which is called as 𝗬𝗲 space. Anteriorly, there is a 𝗬𝗲 space. And posteriorly, there may be a minimal gap known as 𝗏𝗏 space. 𝗏𝗏 space. If a hernia happens through this 𝗬𝗲 space like this, it is called as Morgagni hernia. So Morgagni hernia is most common right side anterior. 𝗏𝗏 hernia is most common left side posterior. In a Morgagni hernia, the common structure to go is transverse colon. In a 𝗏𝗏 hernia, common structure to go is stomach. So which is common of these two hernias? Morgagni hernia or 𝗏𝗏 hernia? Which is common? So most commonly seen hernia is 𝗏𝗏 hernia. 90% of the cases are 𝗏𝗏 hernia. I have very rarely seen a Morgagni hernia. Is very, very rare. Now answer this question. Which of the following is not true regarding congenital diaphragmatic hernia? Transverse colon is the most common structure which herniates in Morgagni hernia. True. Pulmonary hypertension is the most important prognostic factor. Wrong. Bag and mask ventilation should not be done is correct. Stomach is the most common organ herniating in 𝗏𝗏 hernia. Is absolutely correct. So when you see a congenital diaphragmatic hernia, bag and mask is contraindicated. Immediately intubate the patient and wait for 48 hours. After 48 hours only, we do the repair. So prognosis of the patient depends upon the diaphragmatic hernia. Sometimes can be associated with pulmonary hypertension is wrong. Pulmonary aplasia, not developed. The lung is not developed is a major issue in these patients. Okay, aplasia or hypoplasia. Prognosis of the patients of congenital diaphragmatic hernia depends on pulmonary hypoplasia. Don't forget this question. So in a CABG, coronary artery bypass grafting, coronary graft is commonly taken from where? Coronary artery graft is taken from, don't forget, coronary artery, the common graft is taken from most commonly from internal mammary artery. That is the best. So called as 𝗲𝗲. Left internal mammary artery is commonly used, followed by right internal mammary artery, followed by radial artery. Commonly used graft material is an artery, 𝗲𝗲, 𝗲𝗲 or renal artery. If second, after that, we have to take from saphenous vein. Saphenous vein is second option. So among these choices, best answer is saphenous vein. If there is a choice of IMA, I would have gone for IMA because IMA has 90% patency at 10 years. After 10 years, they will be surviving very nicely. Saphenous vein has only 70% patency at 10 years. It can again go for stenosis. So which is best? IMA is the best artery, internal mammary artery, called as 𝗲𝗲. Mickey Mouse sign on B mode ultrasound in patients with varicose veins. Which of the following vessels is not included in the scan? So when I'm doing a Mickey Mouse sign, which is not included in the Mickey Mouse sign, very important question. In our ultrasound of a varicose vein study, you know, this is femoral vein, this is femoral artery, this is great saphenous vein. So when I do in a B mode ultrasound, I will see a sign like this. Femoral vein in the center, long saphenous vein medially, and this is femoral artery. So which of the is not included in the scan is profunda femoris artery is not included in this saphenous Mickey Mouse sign. Okay, don't forget this. So 45-year-old male, a case of varicose veins since the last 4 years, presented with the findings shown in the image. Patient has an history of ulcer over the medial malleolus 6 months back, which healed over 2 months as per CEAP classification. C1, C2, C3, C4A, C4B, C5, C6. C1 is what? What is C1? This is a ulcer, which is a active ulcer. So the answer is C for this, active ulcer. C5 is healed ulcer. C1 is telangiectasia or reticular veins. Reticular veins is 1 to 3 mm veins. Telangiectasia is less than 1 mm veins. C2 is varicose veins. C3 is edema. C4A is pigmentations. C4B is lipodermatosclerosis. Okay. C4C is now added, that is corona phlebitica. Corona phlebitica. So this classification CEAP is very important, and every time they will ask in FMGE exam about this. C5 is a healed ulcer, C6 is an active ulcer. Don't forget this. Aortic dissection. So aortic dissection, all of you know, it's one of the dangerous complications of a patients with trauma as well as hypertension. So hypertension patients will suddenly develop a tear in the aorta. So they will have chest pain radiating to the back is the most common symptom. Yes, that is correct answer. Hypertension is the most important risk factor. Transesophageal echo is done in a stable patient. For patients with a descending aortic dissection, first line of treatment is esmolol. So transesophageal echo is not done for stable patient, it is done for unstable patient. So investigation of choice for a stable patient. So please understand what is aortic dissection. This is arch of aorta. So aortic dissection means there is a tear in the intimal layer like this, and blood starts flowing in a false lumen like this and joins back into the vessel like this. So blood flows in a false lumen because of tear in tunica intima layer. So tunica intima below, there is a false lumen created. So the patients will have pain radiating from chest to back of the scapula. So interscapular pain is seen. So interscapular pain is seen, and there is a X-ray shows wide mediastinum. Please remember, X-ray shows wide mediastinum will be seen on X-ray, and patients will have disproportionate BP. Okay, disproportionate BP between upper limb and upper limb, lower limb. So when I take a stable patient, I will do CT scan. Unstable patients, I will do echo. In a CT scan, these cases, what finding is seen? Can you tell me what is this finding seen in a CT scan? Yes? What is the finding seen in a CT scan? This is known as tennis ball sign. Tennis ball sign. Okay, so don't forget this question. Tennis ball sign. Very good. 45 years old lady presents to the emergency with a severe pain in her hand. She is not having any collagen vascular disease, and the emergency doctor notices the following change in her hand. What is this? So this is Raynaud's phenomenon. Okay, there are two diseases. Unknown etiology is called as primary, also called as Raynaud's phenomenon. Secondary is following a SLE or any collagen vascular disease is called as Raynaud's syndrome. So secondary, remember S for syndrome. So primary is known as phenomenon. Don't forget this point. So what is the cause of her condition? You should go for Raynaud's phenomenon. So Raynaud's phenomenon, Raynaud's syndrome, there are two diseases. So when a patient has any collagen vascular disease, it is called as syndrome. So here it is not mentioned, not having any collagen vascular disease. So I will go for Raynaud's phenomenon. So this is just a phenomenon in which there are three colors seen: white, followed by blue, followed by crimson red on exposure to cold, exposure to cold, vibration, stress, Anything can cause these three color changes called as Raynaud's, which is not seen in India, very common in Western countries. Just remember, Raynaud's phenomenon is unknown etiology. Raynaud's syndrome is secondary to collagen vascular disease. Okay. Identify the stapler shown in the image below. It is used for side-to-side anastomosis in the bowel. Side-to-side anastomosis of bowel. Therefore, we call it as a linear stapler. Okay, it is used as a linear stapler image shown here. Which of the following is the best method for hair removal to avoid surgical site infection? So which of the following is the best method for hair removal to avoid surgical site infection? So please remember, this is a straightforward question. Hair clippers on the table. So shaving before night, depilatory cream, all these are wrong. Hair clippers on the table, you can clip the hair and remove the hair, or just before entering OT. Just before entering OT or on the table is the correct answer for this question. 4 patients came to hospital following a mass road traffic accident. Point out the correct match. The last 10 questions are recent questions. EDH, patient having EDH will have a not pinpoint pupil. They have a fixed dilated pupil called as Hutchinson pupil. Penetrating injury to the eustachian tube will cause not 𝗬𝗔𝗵𝗿𝗺𝗺. 𝗬𝗔𝗵𝗺𝗺 is due to base of skull fracture. Nothing to do with the eustachian tube. It is base of skull fracture. Penetrating injury to eye is causing battle sign. No, it is also due to base of skull fracture. So both these are due to middle cranial fossa fractures. 𝗬𝗔𝗵𝗺𝗺 as well as battle sign, both are due to base of skull, middle cranial fossa. 𝗙ance means unable to move the eyeball beyond the midline. I am unable to see beyond the midline is called as 𝗙ance. It is seen in midbrain injury. That is correct. So this question is a direct FMG question. Sorry, neat FMG question. So please remember this question. 𝗙ance is seen in midbrain injuries. See, a patient with a severe abdominal pain with the nausea and shortness of the breast, CT scan is shown here. What is this question? Already came. See, many times in your FMG exam, you'll have an answer in the upcoming questions. There may be 2 or 3, the same concept will be asked. This is a concept of aortic dissection. You can see a tennis ball sign. Please remember, answer is not urgent surgery. Please don't go urgently. Please understand the answer. I told you aortic dissection is most commonly due to hypertension. The question is asking, what is the next step? Next step is hypertension control plus urgent surgery. A is the correct answer here. So don't go for urgent answer. Urgent surgery is done, correct. But the question is asking, what is the next management? So short-acting esmolol is given, reduce the BP, shift to OT. That is the correct answer. So stable patient. See, the patient is stable. That is why we have done a CT scan showing you tennis ball sign. Reduce the BP. That is very important. This question is asked recently. 50 years old woman presented to hospital with the complaints of mass in the right breast. On examination, mass was movable and further investigation showed left axillary node mass is more than 2 centimeters. No systemic involvement. She had neoadjuvant chemotherapy given before. What will be the tumor staging of this patient? See, there is 3 types of tumor staging. C, TNM, Y, TNM, P, TNM. So C for clinical TNM staging. Y for following a neoadjuvant chemotherapy. P is for pathological TNM staging. So question is very simple. So the question is related to Y. So Y means after a neoadjuvant chemotherapy. So mass in the right side breast with an ulcer. Ulcer stands for T4B. T4 is ulcer in the skin. So T4 is ulcer in the skin. Left axillary node, N1. So therefore, T4B, N1, M0. Please go through TNM staging for breast alone. So only for breast, they will ask you this TNM staging. So please go through this TNM staging. This question asked very clearly. This Y stands for she had neoadjuvant chemotherapy. This is the first time this type of neoadjuvant question came in all the entrance exams. First came for FMG exam. A female presented with a bloody nipple discharge and involvement of single duct. What is the treatment done? So the treatment done for a single duct involved is microdocectomy like this. We have to go for a microdocectomy for a single duct involvement. Simple, straightforward question, repeat question. Which of the following shape of pelvis have recurrent hernia? So recurrent hernia. This question is from Bailey and Love. Short and wide pelvis. So answer is short and wide pelvis will have recurrent hernias. So a patient with history of surgery performed for kidney stone extraction comes to follow-up. The following image is seen here. What is this picture showing you? The picture is showing you a stent. What will I do? This is a double pigtail stent in ureter. Double pigtail stent in ureter. What will I do? Next step done for these cases is I should remove it. Cystoscopic removal. Cystoscopically put it and remove it with the foreign body removal forceps. So it should be removed. It can be kept maximum only for 2 months. After 2 months, we have to remove the stent. So ideal management of this case. Can you tell me what is the diagnosis from this picture? This is a CT scan in showing you a kidney and a ureter with a stone. You can see the classical stone in the ureter. So this is ureteroscopic stone removal should be done for this case. So all these are repeat questions already discussed. So what is the solution used to preserve the graft in organ transplant? When I'm going to transplant organ from one place to one place, what is the solution used to preserve the graft in organ transplant? The solution used is University of Wisconsin solution is the organ preservative solution. So these are some of the important questions for your exams being asked from other specialties except GAT, HBP. So I will share you one recorded video of with the Arise Academy students. Those who are attending the session, you'll get a YouTube session of GAT, HBP recorded already. So if you have time, go through that. But whatever you have already read, you go through it again and again instead of going for a new source of material. So I'm sure you are all going to crack the exam easily with this this session, as well as some more one and a half hours another topic I'll share. If you have your time, you can go through that. So thank you for Arise Academy for giving an opportunity for this session. Any more doubts, if you have, please tell me. I will clear it, or else you will end up. Any doubts in surgery? Surgery is one of the easiest subject. You can crack at least 40 questions. You can easily answer from the 300 questions in FMGE exam. So you can download this PDF in Surgery 6er. I will share there. 𝗵𝗵 Surgery 6er Telegram channel. You can download this. I will share it there. So thank you all. So these topics are all already many times asked MCQ topics. So please go through these topics. Definitely these topics you have high yield, but GAT and HBP I have not covered because of time sequence. If you have time, I will send you one PDF video. You can read that video. Okay. Thank you. General surgery, you will get 30 to 40 marks, no doubt. 40 marks, up to 40 questions, you can answer with only general surgery of the 300 questions. Because a few questions in general surgery, you can answer from